Live. Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Jamal Shillingford from California Orthopedics and Spine. Dr. Shillingford is a minimally invasive, degenerative, and robotic spine specialist at California Orthopedics and Spine. After graduating from the Johns Hopkins University with highest distinction in chemistry, Dr. Shillingford received his medical degree from the Columbia University. Dr. Shillingford then completed an orthopedic surgery residency at the New York Presbyterian Hospital, Columbia and Cornell, where he served as a chief spine resident. He then completed an orthopedic and neurosurgical spine fellowship at the Latham Spine Center in Louisville, Kentucky. He's managed to produce over 35 peer-reviewed manuscripts and has presented at the Scoliosis Research Society, the IMAST, the Lumbar and Cervical Spine Research Societies. He's won several awards, including the Frank Stitchfield Award for Excellence in Orthopedic Surgery from the Columbia University. So today it's my great honor to introduce you to Dr. Jamal Shillingford from California Orthopedics and Spine. Over to you, Jamal.
All right. Thank you for having me. Good morning, everybody. Good evening, good night. I will be talking about robotic spine surgery, which is very near and dear to my heart. And so let's see here. So I will start, this is the outline of the presentation. So I'll start with a case. I'll go through a little bit of the history of robotic spine surgery, what surgical planning looks like, what some of the steps are, and I'll show some videos and images of that. We'll go through some of the literature review, some outcomes, and then conclusions and the future directions of robotic spine surgery. So here's the case. So this is a 57-year-old woman who's had several years of both back and right leg pain. With adult scoliosis, she's had right calf weakness and numbness, and she's failed all non-operative treatment, including physical therapy, medications, and injections. Past medical history, as noted here, double mastectomies, heart disease, and hypothyroidism. Physical exam, she has weakness in her right foot, EHL and gastroc with decreased sensation in the right leg and right foot. Here are some images of the spine. So you can see there's a coronal imbalance, a coronal shift, right-sided. Her global alignment is not terrible, but she does have a coronal curve in the lumbar spine of 31 degrees. She's hypolordotic, so 22 degrees in the lumbar spine with some mismatch between her pelvic incidence and her lumbar lordosis. She does not have any instability. These are flexion extension films, so no spondylolisthesis or instability seen here. Here's our 3D reconstructed image of the thoracic and the lumbar spine for planning. These are some axial images of her MRI showing primarily right-sided lateral recess stenosis at L4-5. And then these are some sagittal cuts, primarily showing the right-sided foramen with stenosis at L4-5 and L5-S1. So the plan was to perform an inner body at the lowest level and a posterior spinal fusion from T10 to her pelvis with a decompression at the L4-5 and L5-S1 level with robotic assistance. So let's go to the history first of pedicle screw placement. So this was first described by Harrington and Toulouse, who described the first deliberate attempt to place a pedicle screw through the isthmus of the pedicle in the 1970s. This was not truly adopted until Roy Camille presented the technique for pedicle screw placement in 1979 at the AAOS meeting. In terms of breaches, which we worry about are breaches when the screw isn't placed perfectly into the isthmus of the pedicle. The average or percentage of breaches that we see in degenerative disease is around 4%, and in scoliosis and deformity patients, it's much higher, with some studies describing about 25%. So this is a paper from Geneva, Switzerland. It's a meta-analysis of 39 studies and 39 papers showing sort of the rates and some of the complications with misplaced screws. So one can have dural lesions with a misplaced screw, and the percentage of that was about 0.2% with malplaced screws. And you can see an image on the right side showing a medial screw which cut the dura, and then a screw that's too long impinging on the vessels anteriorly. So with misplaced screws, you can get nerve irritation, you can get visceral complications, you can get vascular injuries. In this study, they found 32 patients that required revision surgeries for misplaced pedicle screws and neurologic issues from that. So first described robotic spine surgery was in 2006 by Lieberman et al. And this was a study showing screws placed in cadavers with robotic guidance, both pedicle screws and translaminar facet screws. You can see some of the images at the bottom. These screws were placed minimally invasively. Now, if you do a Google search of robotic spine surgery, you will get almost 7 million results. The number of procedures that have been done so far using the Mazor, which is a type of robot, has been over 23,000 procedures. And there are over 150 units worldwide, and this is growing. And accuracy has been boasted to be under 1.5 millimeters for the Mazor robot. Now, who is the robot? Exactly. So I'll show you. This is an image of the current iteration of the robot on the right. So it's a robotic arm that is used to change trajectories and to locate the pedicle for screw placement. On the left is what navigation looks like. So that's a CT image, and you can see real-time placement of the screw. And these two things are now merged as of now. So robotics versus navigation. So with robotics, this is CT based with 3D reconstructions. And the most important thing is it allows for a repeatable process. So the robot arm goes to the appropriate trajectory, which is preoperatively planned. You place a trocar, you drill, you tap through that trocar, you can place a wire, and then place your screw. And this makes it repeatable, it makes it quick and fast. The system holds the trocars in place, and it's very stable, as opposed to navigation where there is no trocar, and there is human error with that. So again, there's a reproducible trajectory, it's more systematic, and there's less human error. So the robotic guidance unit, this is what it looks like. So on the left is the CT-based 3D planning software. The center image at the top is the workstation with the navigation camera and the screen that one sees intraoperatively. On the top right image is the table-mounted robotic arm where the trocar and the cannulas go through to place the screws. The bottom two images are C-arm or fluoroscopy that's used to register the patient and merges the CT scan with fluoroscopy. So some of the highlights of the Mazor robot: it is the first FDA-approved mechanical guidance system for spinal surgery. Accuracy, again, is less than 1.5 millimeters. Over 60,000 screws have been placed. And again, over 23,000 procedures with 150 units worldwide. So some of the clinical applications in spine surgery for the Mazor X Stealth Edition include spinal fixation. So minimally invasive screw placement, which can be done in the degenerative spine. It can be done for spine trauma. You can place transfacet or translaminar facet screws. You can place sacroiliac screws. This can be used in spinal deformities in patients with big scoliotic curves, in patients that you're doing 3-column osteotomies and really changing the alignment of the spine. You can see some of the other applications here. Cement augmentation, you can use it in tumor surgeries and for revision surgeries. So some of the goals of using the robot with navigation: so improvement in the accuracy of screw placement with higher confidence and safety in areas that are difficult. So you also want to reduce your fluoroscopy time. With fluoroscopy time comes radiation to both the surgeon and the patient. You want to optimize and predictively plan the construct preoperatively, which again saves time inside of the operating room. Saving time in the operating room is optimal. So you get the patient out of anesthesia sooner, you get the case finished sooner, which is a good goal. So you maintain a standard operative time, you improve screw insertion times. Again, especially when there's difficult anatomy, this comes in great. So it can be used at all levels of difficulty, again, with minimally invasive surgeries, with percutaneous and complex deformity cases. So we're going to go back to the case a bit. So this is prior to performing the surgery, you need to have a CT scan. So this CT scan can be done either preoperatively or it can be done intraoperatively with planning and scanning. You can do an intraoperative spin with either an O-arm or a Zeem. Where I did my training at the Leatherman Spine Center, we typically staged a majority of our cases. So we would do the inner body work anteriorly or with an XLIF. We would get the CT scan that day after the initial surgery. And on the second stage, then we would just register with the fluoroscopy and place screws the following day or 2 days later. So here's what the preoperative planning looks like, some of the software, and there is a newer version of this software. So you can see, you can plan the trajectory of the screws in the axial plane and the coronal and sagittal plane. So you can look at the harmony of those screws. You can choose the sizes of the screws preoperatively. Again, this is a preoperative blueprint of what the ideal surgery should look like. So here are videos and images of what mounting the frame looks like. So this is actually one of the older versions of the robot, the initial Mazor Renaissance. So this is placing a pin into the spinous process. Now we place the pin primarily into the posterior superior iliac spine. You can also use, you can also use a spinous process clamp to mount the frame. So here's the frame being mounted. And this is the frame where the actual robotic arm will be placed onto. Okay, you can see them mounting that frame to the pin that was placed into the spinous process there. Let's go to the next slide here. So what happens next is you use fluoroscopy to register the patient and the spine to the pre-CT scan that you obtained. Now, once you register the images, then you mount the robotic arm. The robotic arm then goes to the trajectory that has been planned. Here you can see this is a knife being used through the robotic arm and cannula to place the trocar. The trocar gets malleted in place, and through that trocar, one drills, you can place your wire, you can tap, and then place the screw. So I'll fast forward here a little bit, and you can see the drilling that goes through that trocar. So that's the surgeon drilling through that trocar. And then he'll place a wire through that area. And then over that wire, you can tap for the screw and then place the screw. Now, potential advantages include less radiation, like I mentioned before, both to the surgical team and to the patient as compared to minimally invasive surgery with fluoroscopic assist. There is a CT scan that is necessary, so the patient is exposed to radiation for the CT scan. There is less exposure in terms of dissection when using the robot in a minimally invasive approach. Now, the accuracy obviously is a big question when compared to freehand versus navigation versus fluoroscopic assist. So we're going to talk a little bit about that in a bit. Now, the workflow does change a little bit, especially with deformity surgery. So with freehand or navigation, usually the workflow is exposure. You do your facetectomies, you decompress the spine, you do your posterior column osteotomies, then you place your screws with the benefit of an open canal. If you have any difficult screw placement, you can actually feel the pedicle because the canal is now open, so you have access to the pedicle. Then you do your inner bodies and you do your correction. When you're using the robot, you do your exposure, but you don't want to change the spine significantly because that can affect your registration. So you do your exposure, you place your wires, you tap, you can put in your screws or hold out, but at least get your trajectories. Then you do your facetectomies, your decompressions, your osteotomies, place your TLIFs, and do your correction after that. So slight change in the workflow. This is what the intraoperative fluoroscopy images look like for our case. Let's get back to our case. So here you can see what the preoperative plan looked like. So we have all the screws here, screw sizes, screw lengths. on the left, we can see the coronal and the sagittal images of what those screws should look like intraoperatively. Here is an axial image of what the screws look like within the pedicles. These are the sacroiliac screws planned. And then this is what the final construct looked like after utilizing the robot to place it. And so you can see a harmonious correction, harmonious screw placement with global alignment restored. Now, if you do a search for the spine robot in PubMed, you will get over 1,000 results. When I did this search 4 years ago, there were only 200 results. And so you can see that the research has increased significantly since that time. These are some of the studies that I have done in the past, looking at the accuracy of screw placement with the robot versus freehand, and then instrumentation complications, both for the SRS and for IMAST. There is a meta-analysis looking at pedicle screw accuracy with navigation versus freehand. So it's looking at 130 studies, almost 40,000 screws, both in cadavers and in vivo. Overall accuracy is about 91%, and you can see that the accuracy is improved with utilization of navigation. So 95% as opposed to 90% with freehand. This is another study looking at meta-analysis, looking at 30 studies with almost 2,000 patients and 9,000 screws, looking at the accuracy of pedicle screw placement using conventional fluoroscopy versus 3D fluoroscopic navigation. So it's almost 70% with conventional fluoroscopy versus close to 95% using navigation. Now, this is a study that I did looking at just instrumentation complications, which does include malposition of hardware or screw malpositioning, and the incidence in deformity cases for almost 170 patients from 2009 to 2012 with the SRS database was about almost 20 patients per 10,000. And the majority of the instrumentation complications were implant malpositioning. It almost accounted for about 50% of the complications. Now, when using new technology, such as navigation or robotics, there is an increase in screw inaccuracies when there's a learning curve. So this was a study done, I believe, in Germany, looking at screw inaccuracies when adopting a new technology. And so the major peak was between 10 to 20 cases for a surgeon learning to use new technology. So there is decreased supervision. So the surgeon is unskilled but aware. And then, there's a second peak in screw inaccuracies at 40 cases. So at that point, there is increased confidence because, the surgeon is now more confident. They've placed many screws, but they're still in the learning curve. So they are still unskilled, but now unaware. And then after about, the average is about 25 procedures until mastery of that skill. So the conclusion of this study was that a competent surgeon who's adopting this new technology, and this was for robotic spine surgery, needs about 25 procedures with competent supervision to optimize screw placement accuracy. Now, here is a retrospective review of 635 cases at 14 different medical centers, looking at the accuracy of spine implants placed with a surgical robot. And this boasted about a 98% overall accuracy with the use of a robot, with a safe zone of under 2 millimeters. So there were breaches, but a breach under 2 millimeters is still a safe screw. This is another retrospective series looking at 112 cases, comparing freehand screws with fluoroscopic assistance to the robot. And with the robot, you see improved accuracy, so 95% compared to 91%. You see reduced fluoroscopic time, reduced complication rates, reduced reoperation rates because the screw placement was more accurate, and then reduced length of stay in this study. This is a cadaveric study looking at a different type of robot. This is the ROSA, who actually utilized CT guidance, so with navigation initially, and they showed 97% overall accuracy with one screw that had a 1 millimeter breach, so truly 100% accurate. screw placement. This was a prospective study with the ROSA on actual patients. So 10 patients where the robot was used, and then 10 with freehand. And you can see that robotic screws were placed more accurately, 97% versus 92%. This was a study that I did and presented in South Africa at IMAST. And this was a retrospective analysis of our sacroiliac screws placed with the robot versus freehand. And what we found here was that there was no significant difference in overall accuracy or complication rates, so non-inferiority with the robot, so 98% versus about 95% with the freehand. This was a study that I co-authored with one of my partners a few years ago, and we presented at the LSRS showing reliability with the first iteration of the robot, the Renaissance, looking at about 450 pedicle screws and some of the issues that came with the screw placement. So about successful placement, we found 90%. 9% involved registration failure, where we weren't able to register the patient and the images with the fluoroscopy to the CT scan, and then 1% with malprecision screws. And we saw that registration errors and screw misplacement occurred with cases that were more than 3 levels typically. So potential advantages of using the robot include improved accuracy, less intraoperative radiation. There's the ability to actually minimize the skin incision by planning convergence on the skin. And you can see an image of that on the right side here. So you can see where there's the trajectory here of what those screws look like and where the skin incision can be placed to optimize the screw placement and to optimize a smaller incision for placement of those screws. So you also have the ability to choose and optimize implants preoperatively, which is great because now you save time intraoperatively because you already know the sizes of your screws. You already have the ideal trajectory where the robot will place that screw. So you have the ideal sizes and the trajectories. Screw cadence can be optimized preoperatively, which facilitates ease of placement of the rod for fusion. Now you have stealth navigation merged with the newest iteration of the robot, which allows for real-time visualization of your implants. You reduce the biggest advantage, I think, is that you reduce variability, and there is a potential economic impact with improved metrics. So decreased length of stay, less blood loss, less OR time. And this can also be used with complex anatomy and complex procedures. Some of the potential disadvantages I talked about earlier, there is a learning curve. There can be registration problems, which we saw mostly with prior iterations of the robot. Your workflow does change a little bit, so one has to accommodate to that. You do have to use a CT scan preoperatively or intraoperatively, which does cause more radiation for the patient. There is a cost and availability issue again for the robot. So it does cost over $1 million to obtain a robot. It can be used for a maximum of about 5 levels per scan. And you are depending on technology. So there is an impact on resident and fellow training. If the robot doesn't work, they have to be able to know how to place screws freehand or with fluoroscopic guidance, obviously. So some of the, again, this is a case where a robot would not be able to be used, significant deformity with prior fusion and no place to sort of mount that robot. So when is it most helpful? So in complicated anatomy, it can be used. So with congenital anomalies, with revision cases, it can be used with severe deformities. In patients that are morbidly obese, the robot can be helpful. In patients that are osteoporotic, it can be helpful here. Some of the future advancements. So there will be improvements in 3D preoperative assessment. I think there will be also improvements in merging the images with the CT scan as well as with the MRI, which hasn't been done yet. I think as time goes on, we will be able to do more global alignment of the spine with the robot, so utilizing global parameters Intraoperatively, we'll be able to more easily assess 3D rotation, segmental analysis, and then we can incorporate planning software to do our osteotomies and to actually do our decompressions on our deformity correction, as well as more implant positioning advantages with the robot. So again, now we have merging of navigation with real-time feedback. We'll in the future, I think, get stronger robotic arms for more accurate trajectories. I think in the future, burrs, the drills, the bone cutters will be able to be used with the robot. That has not been able to be done just yet. Okay, and then again, it will assist more with deformity correction and contouring rods. Future directions, again, there are many robots in development. There's growing literature. So again, over actually 11,000 so far studies done with increased accuracy, decreased radiation, decreased complications, more than 150 units used worldwide. This is a final case here that I did actually in fellowship with one of my mentors, a more degenerative cases, not so much deformity. And this was a more common use for us with the robot. So the anterior lumbar interbody fusion was done the day prior. We got a CT the same day, and then the following day, we brought in the robot and placed the screws postoperatively. So this is what the plan for what the screws would look like, and then the final product here. Thank you.
Thank you, Jamal, for that brilliant talk of yours. A couple of questions from our side, Jamal.
Sure.
Jamal, I just want to bring to your attention about a paper that was published from Pittsburgh by Alexander Yu and Daniel Mears. We looked at, it was published in Neurosurgery 2019, and they looked at around 67 patients over a 12-month period, and they found that the complication rates were significantly high. With respect that there were 4 deaths. Okay, I don't have the full data, because whether the deaths were due to any surgical complications or another medical complications. So do you think the complications associated with the robotic spine surgery could be higher than a conventional spine surgery?
I don't think that is the case. Usually deaths, I find it hard to believe that the deaths would be related to screw placement. I've never seen that. You can have some visceral injuries, which you can have with freehand screws, if one doesn't pay attention to how long the screws are, or if you're utilizing wires, how deep those wires are. So complications do happen. I think the biggest thing that you see with misplaced screws is if there's skive, and skive is when the actual trocar does move and you do not realize that it has moved. And so with the use now of navigation with the robot, I think those sorts of things, the malpositioning of the screws, you can actually see it in real time going in, will be reduced. Okay.
Thank you, Jamal, for that. Just a second part of the question. I mean, when you think about computers, navigation, robotics, you have the traditional saying, right? Garbage in means garbage out. I mean, if your registrations, there's some abnormality, I mean, some errors in your registration, and you're going to get wrong data from the computer. So do you think in the early stages, or maybe in the first 10 cases with a robotic spine, you have a tendency to risk the anterior body? And because you have the great vessels very close, and even we have seen with conventional spine surgery that people have injured the great vessels.
Yeah. I mean, I think when you are adopting this kind of technology and you're getting used to it, you should actually do it wide open. I wouldn't use this right away in a minimally invasive way. You do it wide open, where you're looking at the anatomy and you can see what that robot arm is doing, so you can get comfortable with it, and you can actually watch what it does. If there's skive, you see it and you can feel that change. And you're watching, you're looking at the anatomy, you're watching to make sure that the trocar is going in the right place, that you feel comfortable using it. And once you do that again for 20, 25 cases, then you can start using it more minimally invasive. Now, again, you can have issues with registration. You can have issues with just navigation. Sometimes we see that, where the navigation seems like it's off. If you feel like something is off, you stop using it. You check the navigation based on anatomy. You get x-rays, because you have any spine surgeon, any facility has fluoroscopy. So if you do not trust that, you get fluoroscopy in there to check And if you feel like something is off, you can try to re-register, you can do an intraoperative spin, or completely not use it and go back to, again, your normal technique with anatomy, wide open, fluoroscopy. That's what I would recommend.
Thank you, Jamal, for that.
Yep.
And Jamal, what about the advantages of a robotic spine? So do you think the biggest advantage in a robotic spine surgery is the accuracy of the pedicle screws? And what about placement of your cages and all the work that you do on the anterior side? Does it offer an advantage? Does the robo has any superiority for all the anterior work that you do?
At this point, the robot doesn't do anything for the anterior component of the case. We have used navigation to place implants when doing things like oblique lumbar interbody fusions, where you can see it on the navigation screen with your curettes and your shavers, but the robot has not yet added that to its armamentarium. I think the advantage to using the robot, again, is accuracy, but even more so, I think the preoperative planning is what helps a lot. So you can plan, again, those screws, you can plan your perfect trajectories, you can plan the screw sizes, so you're not thinking about, as you're putting in freehand screws, looking at your probes and measuring sizes. This all saves time in the operating room and gets the patient off the table sooner. So accuracy is better. Placing the screw, I think, does save time. And then you already have your implants, your trajectories, your harmony already planned preoperatively. I think that's where it helps the most. And again, in patients that have significant deformities where you will have some difficulty placing those screws, or bigger patients where it's deep and the visibility is poor, I think the robot is very helpful there.
Thank you, Jamal, for that. Just one last question before I end the session. Yeah, so you mentioned in one of your slides that a complex spine deformity you should be very careful in using the robo, right? So is there a real advantage in the complex spine? Because in another slide of yours, it says in advantages, a complex deformity can be very well addressed with the robo. So those are
it depends on the level of complexity. So the really, really complex spine, I don't think the robot is to be used in that. But I remember those images that I showed you. So I think in some deformities, it can be used in patients with smaller pedicles. But when you have a significant deformity that is fused, I think it's going to be difficult to mount and utilize the robot. And these things are being figured out as we speak. So, I don't have a perfect answer as to how complex of a deformity the robot can be used, but I would start with obviously smaller curves, and as time goes on, you use it with more and more, slightly more complex spines, and I think at some point we'll find the limit of what it can do. But I don't have an answer for the specific limit of the type of curve and degree. I don't have an answer for that at this point.
Thank you, Jamal. I think that's all the questions that we have for this session. Thank you for fantastic lecture, and I'm sure this is going to benefit a lot of people all over the world.
Great. Thank you for having me. I appreciate it.
Thank you so much.
All right. Bye.